So I'm really sorry to hear that you have a patient that is lame 1 year after its cruciate surgery. These can be difficult cases to deal with and frustrating for everybody. So know that the information I'm about to give you is good for pretty much all the types of cruciate repair procedures, whether it be a TPLO or an extra cap repair. This is a general go-to action plan for that patient. So you're going to start with a really good history and orthopedic exam. What you want to establish is it really the same leg that had the surgery a year ago? Go to your records. Don't believe what everybody's thinking. Have a good look. 2, is the pain really coming from the stifle, or is the lameness really coming from the stifle, or is it another joint or body part sore on that leg making them lame? 3, is this actually a new lameness 1 year or so after the surgery, or is it an ongoing lameness? And although your approach to the problem may be similar, whether it's a new or ongoing lameness, know that the ongoing lameness can be a lot more difficult to treat because we've got a year-long history of problems that we have to undo and unwind, and one problem leads to another that leads to another. So there's a lot of work to do in those patients, and it can take a lot longer. And it also may be that you don't have the most compliant client to be dealing with. And I'm not necessarily blaming the client for this. It may also be that the patient was discharged too early with inappropriate information, and the clients did the best they can. So let's in turn help them out and do the best we can. So once you've established that yes, it's the same leg, yes, it's the stifle, and nothing really on your physical exam is yelling at you, oh my God, here's the problem, take x-rays. Take a set of radiographs, mediolateral, caudocranial radiographs of the stifle. And again, I'm going to assume that there's nothing obvious showing up on the x-rays that is going to lead you to a treatment plan. So now we've got a dog that's lame a year after cruciate surgery, and we don't really know why, but we know that he's lame. So there's a lot of things to be thinking of. One, it could be a low-grade a low virulence septic arthritis going on. It could be some infection in the implants, especially with the TPLO type situation. It could be an OA aggravation trauma kind of event that caused the OA just to really flare up. We'll need to get that back under control. It could be, if it's an ongoing problem, that we just never got better because we never established a good rehabilitation program and that the patient just never relearned how to walk properly on that leg. It could be a meniscal problem. It could be other things, but let's just start with an easy approach. We have our physical exam, we have our history, we have our x-rays. I'm going to put this patient on antibiotics. Why? Because it's a quick, easy way to rule out the infectious process. I'm going to pick a cephalexin or clindamycin, and I'm going to give them about 2 weeks of antibiotics. After a week, not somebody in my department, but I am going to call the client to find out how the patient's doing. If I get oh my God, Dr. Sylvester, he is doing so well. He's like a puppy again. I've got my dog back. Thank you, thank you. I know what the problem is, and I'm going to keep on going down that path with antibiotics and treat for the appropriate period of time, which will often be about 6 weeks. If I get a response like, yeah, well, he might be doing a bit better, but not convinced that he's so much better, then not an infection. Let's move on to plan B. And with plan B, I'm going to do non-steroidal anti-inflammatories. So bracket here, get some blood work because I'm going to use them for a fair period of time. And I'm going to start with 2 weeks worth and a good rehabilitation program. Now, if this is a brand new lameness, I will start with a couple of weeks of rest before I jump into a rehabilitation program. But I will start with the NSAIDs. I'm often going to be dealing for NSAIDs for at least 4 weeks. I'm going to recheck the patient every 2 weeks, and I better see an improvement every time I check them. If I really am not seeing an improvement, then we just need to move to plan C, which is surgery. And at surgery, I am going to check the menisci. I am going to get a sample for culture, maybe pathology, sample of the synovium for culture pathology, and I will remove all implants. Then I will make sure the patient gets into a good rehabilitation program. This approach, most of the time, will get me to where I want to go, and that is a pain-free patient that can exercise while not needing to be on daily anti-inflammatories. So, won't be perfect, but it's going to be way better. We're looking for quality. Thank you. Have a wonderful day.